I think there's no need to introduce him, but still he's a professor for radiation oncologist from Maastricht. He's internationally absolutely well-known expert in thoracic oncology, and he will give us an update on what did he say, classical patient with localized small cell lung cancer. So not non-small cell, but small cell now. Dirk, please.
Thank you very much for the invitation. Actually, the title was not given by me, so I'm very glad for whoever gave the title. But anyway, I will try to give you some ideas about and some discussion about how to treat so-called localized small cell lung cancer. And I say so-called localized small cell lung cancer because the question is there something like a localized small cell lung cancer when there's lymph node involvement? These are my disclosures. So I will go through a real patient that was also said to me, so it should be a case report. So this is a 64-year-old, of course, female. She has increasing dyspnea the last 4 weeks. She has a COPD Gold 2, no weight loss, good performance status, 50 pack years. And then we did a whole body FDG PET scan. There was no metastasis. And we did also a contrast enhanced MRI of the brain, no visual brain metastasis. And this is the picture. And this is about the same as can be visualized on the PET-CT scan. So very easy. So who of you would also agree with me at this point that until now we were right with the imaging, so the staging of this patient? And we obtained, of course, histology, that's no question. But who would agree that we did in this patient an FDG PET-CT scan and MRI scan of the brain? Who would agree? Okay, so fortunately there's also people who would disagree. Who would disagree? Two, okay, fantastic. Because indeed, that's what we do in our center. Those patients get directly an FDG PET scan if they are in a good general condition and so on. However, then I go to the ESMO guidelines. Oh, ESMO guidelines, you know those people here, some marginal ones, also be co-author. And then, yes, what do I read? An FDG PET-CT scan is optional. However, maybe a bone scintigraphy. Oh, that's already something where we would say, why would we ever do that? And that's already the first thing. Well, we know that there's a lot of small studies showing that indeed the accuracy, both the sensitivity and the specificity of FDG PET scan is much better than a bone scintigraphy. But of course, we don't have large data sets. We don't have the proper good studies like we do have in non-small cell lung cancer. And that's already a starting point. Is this correct what we have done? We do it, but in a lot of countries, and a lot of people in the room know that, when you try to roll out a study in different countries, you end up with the story that in a lot of countries, this is really not reimbursed because they say in the guidelines it is still stated that the bone scintigraphy is the standard of treatment. So this is something what we should do something about it, I think, because otherwise we will still continue with this issue about the staging of small cell lung cancer. And again, this was very obvious in the first place, but still, did we do it according to the guidelines? And then it's very easy if you look at the guidelines. Again, the ESMO guidelines, patients with so-called localized disease, so T1, T4, and 0 and 3 tumors in a good general condition should be treated with concurrent chemotherapy and thoracic radiation. It should be twice daily, given with cisplatin etoposide, and then afterwards patient could be offered a PCI. Okay, our patient, she received 4 cycles of cisplatin etoposide, and from day 1 of the second cycle, she received also twice daily irradiation with, for the radiation oncologist in our room, a hybrid VMAT technique. So that means in practice, you give, at least we give, about 60% of the dose APPA and then the rest with the rotation technique in order to spare the lung as much as possible and still obtain a quite reasonable conformality of this quite complex lymph node involvement. She had a good response even on the CT scan, and she is still in a pretty good general condition, so the treatment was quite well tolerated as well. Now, if you do this type of treatment, you may also question, is this a good way to look at the response with CT scan? Because if you look at CT scan, you always see some residual mass, and we know, for instance, from the Teresi trial, that a CT scan and even a PET scan in other trials is not a very good way to evaluate the response of chemoradiation, because you have a lot of scarring tissue, a lot of inflammation. And if you have a residual mass, you don't know what is this. Is this still viable tumor cells? Is this an inflammation? What is it? And we know that after these types of treatment, you have more than 50% of the patients have a false positive FDG uptake to some extent. So we all do a CT scan, but the question is this a reasonable way to do it? And I should caution to not to overestimate the value, unless you have new lesions, of course, the value of, at this moment, diagnostic imaging in those patients. And then you may also say, well, why should we give twice daily irradiation, and why should we give early irradiation? Now, early irradiation, why should we do that? This is a large study we did several years ago. This is based on randomized evidence. And actually, we look at the 5-year survival rate as a function of, we couldn't find something better than the SER, that's to say the start of any treatment to the end of radiation. And basically, it's built on a lot of data out there showing that small cell lung cancer is a highly proliferating tumor, of course, but doesn't have a proliferation gap after starting the treatment. Basically what it says is, if you irradiate, for instance, an adenocarcinoma, most of the time cancer cells only start to die after 4, 5, 6 weeks after being irradiated. So that means you have, let's say, a time window of 6 weeks or something where you can deliver your treatment without being too much stressed by highly proliferation of accelerated proliferation of tumor cells. But in small cell lung cancer, this is a totally different disease. It directly proliferates at a very high level. And therefore, if you give the whole package of the treatment, so both the radiation and the chemotherapy in, let's say, within something like 60 days or so, you achieve about 20–25% of 4 or 5 year survival rate. Whereas if you give it quite slowly, then you end up with something like 10% on the long run. I should stress, this is based on about 2,000 patients, randomized evidence, and the only difference between the different arms is the timing. So they receive the same chemotherapy and the same radiation. So the timing is very important in small cell lung cancer, certainly if you compare this with adenocarcinoma also originating in the lung. Now we extended this much more, and this is based on an update of all randomized studies throughout the world, except for one Korean study where we couldn't obtain the original patient data. All of the patient data were updated, and this is based on the minimum follow-up of 8 years of those patients. Now, there are studies, randomized studies, where they looked at what some people would call the compliance of the chemotherapy or the radiation. Compliance meaning that you will give a certain dose in a certain time of the chemotherapy. So then you end up with different groups. You have the similar compliance of chemotherapy and you have different compliance. So that means that you have a lower dose of radiation in one arm compared to the other arm. I should again stress this is based on randomized evidence. This is not a post hoc analysis on some patients which receive a lower dose of chemotherapy or radiation, because then you may question why is this. And then you have the earlier or the shorter radiation. So earlier means you start your radiation within, let's say, 60 days after the first deliverance of chemotherapy, and shorter means accelerated radiation. You give the whole radiation in a shorter period of time, because you know from a Teresi trial that then you have a better overall survival at the long run. So then you have 4 groups, and you see directly that the best survival at 5 years and longer, an absolute survival difference of about 8%, is achieved when you give a good chemotherapy with early radiation and accelerated radiation. And the worst results are when you give bad chemotherapy. And then it doesn't matter whether you give your radiation quickly, intensively, or whatever. That is actually the take-home message. And when you give good chemotherapy, then indeed it matters with 7% that you give your radiation quickly and also in an accelerated way. That is what those data, again based on about 2,000 patients, show. So the take-home message is, you should never compromise the systemic treatment in small cell lung cancer. But if you give good systemic treatment, yes, your local treatment does matter how you deliver it. I think this is a take-home message. And this is also why in this patient, and in all patients in a good general condition, and that's to say a WHO performance status of 0 to 1, they receive cis etoposide without compromising as much as possible the dose, and then quickly from, let's say in practice, on the beginning of cycle 2, we give twice daily radiation. But then, is it needed to give twice daily radiation? I hear a lot of colleagues saying, well, twice daily radiation is a burden to the patient, and so on and so forth. But the question is, what is the benefit for the patient? And I've shown you that indeed it's beneficial for the long-term overall survival. And I would question if a patient wouldn't like to come twice daily, 3 weeks to a radiation oncology department, if you can show him or her that indeed the long-term survival rate absolutely is about 8% higher. We do more stupid things for lesser gains, I think. Anyway, Corinne Friend from Manchester, she did a big randomized trial, the CONVERT trial, and that was a randomization between accelerated radiation, twice daily 1.5 Gray versus 66 Gray in 33 fractions. So it was limited stage small cell lung cancer, bad name. I'm also in the writing committee of this study, so indeed it was a big name, but still we said, well, most people still use limited disease, but of course we should use the TNM staging. And then afterwards randomizing from cycle 2, day 1, between accelerated radiation and 66 Gray. And then look at here. There's a small restaging that's based on CT scan, and when there's no progressive disease, patients received PCI. Again, on purpose we said it should be no progressive disease, again because there's really hardly a difference in long-term survival between complete remission, partial remission, and stabilized disease. And this is not because there's no difference, I think, from a biological point of view, but because we lack imaging which allow us to distinguish those 3 groups. That is basically what it shows, I think. Anyway, this was the result. The primary objective was to show a difference in overall survival in favor of the once daily arm, so to say the 66 Gray arm, to 56% at 2 years, and the BID arm, so the standard arm, 44 Gray. Actually, if the hypothesis, what we published 10 years ago, was correct, then actually the twice daily arm should be a little bit better. And it was a little bit better. There was no difference statistically in favor of twice daily irradiation, but I should say this is a non-inferiority study. So that means the hypothesis and the sample size was calculated to show a beneficial effect of 66 Gray. And it doesn't come out of it, so twice daily still remains the golden standard. But of course, it's also interesting to notice that nowadays with twice daily irradiation, we achieve a 2-year survival rate of 56%, which was exactly the same. If you would try to do it, you couldn't do it, but exactly 56% as what was hoped to achieve with the experimental arm being the 66 Gray in 33 fractions. And then you see even then a 43% of 3-year overall survival rate. So again, no significant difference, but it was a non-inferiority trial. And still, for this type of disease, not too bad results. And it's very interesting, it's not yet published, to look also to what is the effect of the PET staging. And Corinne has shown this, or the result, at the World Lung Cancer Conference last month in Vienna. And because 50% of those patients about were staged with PET-CT scan and 50% not, because according to the guidelines you should not use PET-CT scans. So in a lot of centers or countries there was no PET-CT scan used. And what is striking that is that the beneficial effect of PET-CT scan is not that much as I would have expected. So if you have some areas where you have probably some uptake, and probably also you see on CT scan some anatomical substrate for the FDG uptake, possibly those patients are more in line with the so-called limited stage. So I'm keen to see the final results of this subgroup analysis. The patients were, by the way, stratified according to PET or no PET. So I think statistically this was also done very properly. So again, I hope that Corinne will publish this pretty soon, because this will be very interesting for an update of, for instance, the ESMO guidelines. Acute toxicity was much lower than in historical series. So first of all, esophagitis, which is of course a major concern if you combine chemotherapy and radiation, whether you give it once or twice daily. Grade 3 esophagitis, so that's basically tube feeding, was in about, even in the twice daily arm, about 19%. So really no statistical difference. Why is this? This is because this trial was done based on selective nodal irradiation. For the non-radiation oncologists, this means that you will not irradiate the whole mediastinum, as was done in most historical series, no, only the CT or the PET-CT based nodal involvement. This is actually based on a phase 2 trial we did about 10 years ago, where we showed that this approach was safe. And actually we also obtained 18% again grade 3 esophagitis, compared to about 30% with the classical Teresi regimen. So we give again twice daily irradiation, and in the Teresi schedule it was 30% of grade 3 esophagitis. Now it's about half, no, a little bit more than half, 18%. Just by not better radiation techniques, but by more focused techniques. And this is very important for the patients. And again, whether you give twice daily or once daily irradiation, it's really no difference at all for acute esophagitis. And look at also to the very severe pneumonitis, 2%, and grade 1 and 2 dyspnea was about 20%. So quite well tolerated. Okay, and then we have the PCI issue. I don't have time to go into detail. We offered our patient PCI, but in a randomized study. Why? Because if you think about PCI, there's a lot of questions which are still open, I think, at this moment. We all know that the meta-analysis of Anne Opérin from the late 1990s showed that there's indeed an improved survival in so-called limited stage small cell lung cancer with PCI. The survival, by the way, the survival benefit only occurs after 2 years. So the probability that it's due to non-detected metastasis is quite small, I think, because otherwise you would see the difference already occurring quite early, and it's now only after 2 years. There's a beneficial effect on overall survival, but on the other hand, there's also concerns about toxicity, most of the time about the effect on the neurocognition. And therefore, we are now doing in Flanders and in the Netherlands a randomized study, and we have now included more than 100 patients in that study, where we look at the effect of the avoidance of the hippocampus in order to spare the memory function. That is basically the aim of the study. And so those patients who receive PCI, extensive and limited stage, they are randomized between hippocampus avoidance and standard radiation. And then they are receiving a lot of functional MRI, but the primary endpoint is Hopkins Learning Scale. So that's the primary endpoint, the recall score on the Hopkins Learning Scale. And actually the aim is to have a success that means less than 4 points of decrease of recall. I should also say this is a quite challenging study, not only because we do a lot of functional MRI and hence we diagnosed quite a number of patients who don't have brain metastasis on a regular MRI, but we see them now in a more advanced MRI setting. But what we also observe is a lot of functional or neurological decline due to the chemotherapy. Also, that is important. Actually, what we observe is that the memory decline due to chemotherapy is about the same as the additional memory decline due to radiation. So actually what we have in small cell lung cancer, we have patients at baseline which have a bad memory function compared to the matched age controls of their, so age and gender matched controls. So you start already with impaired memory. Maybe this is because of smoking, maybe this is because of paraneoplasia. Then you have the effect of the chemotherapy, and on top you have the effect of the radiation. Everything adds on. So that's something what we should remember also. And what we also, this is more for the radiation oncologists, these are the technical details, but we try to decrease the dose to the hippocampus from 25 gray to about, well, say 6 or 7 gray. And this should be enough in order to spare the hippocampus. If you have questions, I will be glad to answer them, also based on a lot of preclinical mice data, why this should be something where we can show a difference between the two arms. It's not that easy to delineate the hippocampus. I think the radiologists would agree on that. It's very important that we do a very proper standardization. We have done this in 2 countries, and I can assure you it's much more difficult than it would seem, and there's a lot of variability also depending on the software you are using. For instance, we have seen a few months ago that Siemens has updated the software, and all of a sudden there was a 30% difference in the volume of the hippocampus. So we had to recalibrate everything, or every center which was using the new Siemens software. So therefore I would also say or stress, please don't use hippocampus sparing outside of a well-done clinical trial. First of all, we don't know whether it works, and we don't know whether we will have more metastasis. This is a secondary endpoint. And second, it seems easy, but it's not easy at all. Not from the technical point of delivery of the radiation, but the technical control. We do volumetry, we do functional connectivity mapping. It's very interesting what comes out of that. And we do, of course, also the structural connectivity based on DTI, on up to 60 directions. And then you have those very nice pictures which allow us to look more in detail what is happening to brains being irradiated, being exposed to chemotherapy, and what is the evolution in the brains of those patients. And we have also data that inflammation plays really a major role in the neurocognitive side effects, not only of radiation but also of chemotherapy. Having said that, we have those patients, and our case of the patient I showed you, but like many, and I would say the majority of the patients, they will develop ultimately metastatic disease. And therefore I think when we should move the field forward, we can try to improve the side effects, like hippocampus sparing, but I think for the overall survival, we should really do something on distant metastasis, because I think, maybe Matthias would agree or not agree with me, because I think that at this moment, intensification of the local treatment, I don't think there's something to gain unless to reduce toxicity. And therefore, one of the ETOP trials, which is coordinated by Solange and me, is trying to improve the systemic failure, actually, in order to combine the standard treatment with immune treatment, nivolumab and ipilimumab, and then followed by nivolumab. And on purpose, we have chosen the combo because we know that, and we heard it this morning as well, that small cell lung cancer is a totally different disease than adeno or squamous cell carcinoma, and we need probably something like ipilimumab in order to increase the immunogenicity of the small cell lung cancer. And I hope that this study will enroll better than we do now, to be honest, because this may really, hopefully, well, improve the overall survival, because we really need that in the future. So, conclusion, early concurrent chemoradiation, twice daily, followed by PCI, in patients with a good general condition, I should stress that. And I think really we need to do something more innovative than what we have done, unfortunately, the last 10 years or something. Thank you.